Good morning, class. My name is Tomeka Hill. I am very honored to present my DNP project titled Reducing Opioid Overdoses Through Harm Reduction Strategies. Such a time to get here, but I'm so happy that I'm actually able to give this presentation here in this class, actually. This project focuses on the implementation of harm reduction measures such as medication assisted treatment. A lot of us know as MAT, hold near dear to my heart. I really love to help these people. Naloxone distribution and needle exchange program as a means to decreasing the opioid related deaths, not just in the two clinics that I did my research in, but I'm hoping to do this around the world in various different states. So that's my long-term goal, just to throw that in there. However, as we are all aware, this opioid crisis continues to devastate communities across the United States. It makes this research timely and critically important. So the goal of my presentation is to walk you through the essential components of the project, the background and significance, literature review, the theoretical framework, methods, findings, implications of practice and policy. And hopefully by the end of the presentation, I hope to have illustrated how these harm reduction measures can be integrated into the healthcare setting, helping to improve patient outcomes and ultimately save lives. So first, I would like to give homage to my committee. First of all, Dr. Buck, who's my chair. Second of all, I had the reader Amari Watkins. She's in criminology, for forensic criminology. So she see a lot of these overdoses. And then actually, Crystal Winder, who was also one of the personnel at one of the clinics who actually helped to navigate back and forth with giving me the information because I did not have direct patient care. So I like to pay homage to those people. Uh, when now let's look at uh, the background significance. But before we begin, I want to express my deepest gratitude to those committee members because they actually helped to provide invaluable insights and guidance throughout this project for me. My committee, such as Dr. Buck, she has been instrumental in ensuring that my project aligns with the DNP scholarly expectations and its rigorous understanding and implementation. So my second reader, Amari Watkins, she provided insightful feedback, but also constructive criticism. But it helped refine my research approach, actually. And then finally, that I wanted to name Mrs. Winder played a vital role in connecting the research findings to like real world applications. So this intel helped me to ensure that the project remained practical, but as far as put it also providing an impact for patients and providers alike. So all three of their supports and expertise on my committee have been essential in bringing this project together and fruitation, basically making it fruitful. And I deeply appreciate their dedication to advancing nursing practice and patient care. So now back to background and the significance. We know the opioid epidemic has had devastating effects on communities all over the United States. 100,000 opioid-related deaths has been reported in the United States annually. Was in my CDC references from just in 2023. Despite extensive public health efforts, opioid overdose continue to rise. It demonstrates the need for alternative evidence-based interventions. So traditional abstinence only approaches to opioid use disorder, OUD, which often fail to due to the high relapse rate. And so that very chronic in nature when it comes to addiction. As a result, there is a growing emphasis on harm reduction measures. So these measures focus on minimizing the negative health and social consequences of opioid use rather than solely enforcing just its abstinence. Harm reduction strategies such as MAT, you hear me say often throughout this project, but also known as medication assisted treatment, such as the naloxone distribution, needle exchange program, has been shown to reduce those mortality rates in the two southern clinics in Chicago, Illinois, in which I did my research in. So overall, it improved treatment retention, it promoted safer drug use practices. However, there's still a stigma that surround these things. So of course, there's lack of provider education, limited access to those services. So remain significant barriers to widespread implementation. So that's something that we as a people have to continue to work on. This project seeks to evaluate the effectiveness of these harm reduction strategies in reducing opioid-related mortality and by improving patient outcomes, of course, with the particular focus on integrating them into healthcare settings, okay? Now, let's look at the review of literature. The review of literature provides strong evidence which supports harm reduction measures as effective strategies for mitigating opioid-related harm. Research by Sullivan et al. 221, that's also in my reference, found that patients that received MAT had significantly lower risk of opioid-related mortality compared to those who attempted just the abstinence-based recovery alone, right? So that assistance is needed. So it's a stigma around it, but it shouldn't be. We need to educate, like, okay, this is the process, the stepping stone. You must crawl before you walk. So MAT, which includes medications such as methadone, buprenorphine, naltrexone, Suboxone, has been widely endorsed by public health organizations for its ability to stabilize patients and reduce withdrawal symptoms. I have so many stories with that, but moving on, because for the sake of time here. But another key issue identified in the literature is stigma, and it's stigma so big. If I can write it, stigma will take up my whole slide. But studies show, such as Friedman in my references 2020, highlighted how negative perceptions of harm reduction services deter both patients and providers from engaging in these life-saving interventions. Johnson et al. In 2020 emphasized the importance of non-judgmental care and the provider education and improvement treatment adherence. So additionally, Smith said the same thing in that reference to explore the role of socioeconomic factors, noting that disparities in healthcare access significantly impact the effectiveness of harm reduction efforts. And I have too heard these from my own personal patients that I provide MAT care to. The stories is horrendous sometimes. So now, next slide, the theoretical framework. So we got the health belief model, which serves as the theoretical framework for this project. The health belief model is widely used in public health research to understand how individuals perceive health risks. Their benefits, barriers, and also behavior change. This model was selected because it provided insight into why individuals with opioid use disorder engages or fail to engage with harm reduction strategies. For example, a patient perceives susceptibility, right, to overdose. They may influence their willingness to participate into a naloxone distribution program. Likewise, if they view MAT as beneficial in engaging, if they view MAT as beneficial in managing their withdrawal symptoms and improving quality of life, they may be more likely to engage in treatment. So education, knowledgeable. However, perceived barriers such as that stigma and accessibility often prevent patients from seeking care. So, by addressing just these barriers alone, this project aims to enhance the effectiveness and uptake of harm reduction measures interventions. Methods and designs. So I utilize mixed method approach. It incorporated both quantitative and qualitative data methods. Qualitative components involve analyzing the opioid overdose rates and treatment retentions among patients enrolled in harm reduction programs. The qualitative component consisted of semi-structured interview with patients and healthcare providers. This helped to gain insight into their experiences, attitudes, barriers of harm reduction strategies. So that really helped. My pre and post intervention. I put that there. Now it's right here. So my pre and post intervention. Can't go back. I'm sorry, but design was used to compare outcomes like before and after. So implementing those harm reduction measures, design was chosen because it allowed for direct measurement of change in overdose rates and patient engagement over a period of time. This combination of qualitative, quantitative data provided like a comprehensive understanding for me and how harm reduction measures that I implemented made an impact on opioid related outcomes. So now we're going to look at the sample size. The study that I did consisted of 149 patients diagnosed with opioid use disorder or OUD. Participants were recruited from community health clinics and addiction treatment centers in the southern part of Chicago. And the ones they offered harm reduction services already. The demographic breakdown of the sample was as follows. So, average age of the patient was 34, but again, between 18 and 70 years of age. 60% were male, 40% were female, 70% was from low income backgrounds. And of course, that's kind of where you're going to find those type of clinics, which also make it bad when they're doing like methadone and all that stuff. So yeah, so that's a big issue too. But however, by selecting a diverse sample, the project aimed to explore how different population engages with harm reduction interventions, and it helped to identify potential disparities in access and its effectiveness. So now we're going to look at data analysis. Quantitative data were analyzed using paired t-tests to assess changes in opioid overdose rates and treatment adherence. So we had pre and post interventions. Descriptive statistics were used to summarize the demographic information and overall program effectiveness. For qualitative data, the thematic analysis was conducted. This analysis was conducted on patients and provider interviews to identify recurring themes, such as like, was it the stigma? Was it the patient's accessibility? Their perception of the harm reduction measures being effective or not effective? So by combining these statistical and thematic approaches, the study ensured a robust evaluation of harm reduction interventions, okay? Now we look at the results. The results of the study demonstrated a significant reduction in opioid-related deaths and increased treatment and adherence to this day, right now, and to this day. Among participants that engage in these harm reduction programs, some of the key findings included like 30% reduction rate in opioid overdose deaths following these interventions implementation, 25% increase in treatment retention rates among patients receiving MATs, positive quality feedback from patients, which is important, and the providers regarding the program effectiveness. Okay, so these findings suggest that harm reduction strategies are both effective and well received in clinical practice. So now let's look at limitations. Limitations. Here's that word again, stigma. Like any other research study, this project had certain limitations that must be acknowledged. Okay, one primary limitation was the sample size, generalizability. I'm sorry. While 150 participants provided valuable insight, a larger and more diverse sample, of course, would have strengthened the findings and improved applicable across different populations. However, additionally, the study focused on specific community health settings, which may not fully reflect the challenges faced in rural areas or regions with limited access to harm reduction programs. Another key limitation was self-reported data. In the qualitative component, participants' responses may have been influenced by socially desirability, biases, recall biases, affecting the accuracy of reported experiences with harm reduction strategies. Furthermore, short-term follow-up prevented the assessment of long-term treatment adherence and relapse rates. So future research should consider a more longitudinal approach to better understand the lasting impact of these harm reduction measures. As we go into the discussion, the results of this project align with existing literature, of course, supporting the effectiveness of harm reduction strategy. It helps to reduce opioid overdose deaths and improve treatment retention. The 30% reduction in overdose rates and 25% increase in treatment adherence suggested that just by integrating these harm reduction measures into the clinical practice, one can have a significant improved patient outcome, which we look for. These findings reinforce the importance of expanding access to medication-assisted treatment and knowing which one is the best for the patient, and then also ensuring that your patient knows and have access to naloxone distribution sites. You're prescribing naloxone with any of the opioids, and also giving them access to needle exchange programs. One of the most important takeaways from this project is the critical role of provider education, and destigmatization. We should not stigmatize our patients. We should make them feel comfortable. We should listen to them. We should listen to their concerns. So they're less reluctant to not complete the program, because someone going to a methadone clinic to pick up methadone and crossing their drug provider every day and being in that environment and talking to people that's on several drugs honestly can be more tempted if you as a provider are not well educated and does not well educate your patient. So you can be helping them but also hurting them at the same time. Okay, so we as providers must take that critical role with education and destigmatization. Okay, the qualitative data indicated that stigma from healthcare providers remain a major barrier, even though to harm reduction engagement. Addressing these biases through training and policy change is essential in improving patient interaction and ensuring harm reduction is fully utilized as a life-saving strategy. Okay. Implication into your practice. The findings of this project has several important implications for nursing practice, healthcare systems, and policy development. First and foremost, they emphasize the need for harm reduction training in nursing education and clinical practice. Nurses play a vital role in this in patient care and ensuring that they are equipped with the knowledge that they need when it comes to these different harm reduction measures or strategies can highly help improve patient engagement and reduce that stigma and enhance treatment outcomes. Additionally, this project highlights the importance of integrating those harm reduction measures into primary routine care and mental health service. Like mental health go good and along with addiction therapy. Sometimes even when I'm doing family practice, I can do addiction therapy. I can, make sure I'm doing my cage and, any other addiction or prevention program as well. So it's good to practice holistically, depending on what type of provider you are, but the more holistic you are, the better. And you're treating your patient as a whole, and you can get to cut down on a lot of these opioid related deaths because it's really running rampant now. Rather than being limited to specialized addiction treatment center strategies like MAT and naloxone co-prescription, one should be normalizing all healthcare settings. So, of course, putting it in each and every setting that's out there that has patients. You never know, because we have to also keep in mind when we talk about opioids, we're talking more than just heroin and cocaine. We're talking about pain medications. We're talking about Xanax. We're talking about all of those controlled substance that requires that. DEA, or you check the prescription monitoring drug program. Those things, that's very serious, okay? Nurses can advocate for policy change that increase findings for harm reduction programs, expand access to care, and remove barriers such as restrictive prescribing regulations. Conclusion. So in conclusion, I like to say that harm reduction strategies help to overall reduce deaths and improve treatment adherence. It also helps us focus more on the future, help us to scale more when it comes to harm reduction strategies and access barriers to patients getting help, like number one, the stigma that surrounds addiction therapy and medication assisted treatment. Because believe it or not, a lot of people want help, they just don't know how and where to get the help, and a lot of them don't want to go to methadone clinics in person. They would rather do it online because online they don't have to face their drug dealer while they're walking to the methadone clinic to get mats, or they don't have to come in contact with other drug users that may be even more impactful than you as a provider, because they're still in their recovery state, as they will always be recovering, but they're in a more vulnerable recovery state. So we have to definitely keep that in mind. And when you look at personal impact, the DNP program reinforced this importance of evidence-based practice and patient advocacy. We should always do that and be our patient advocate. The next slide just really talked about all of my references that I utilize for pretty much this PowerPoint exercise, but not for my whole project. It was an array of them that I've used since I've been doing my research. But overall, I hope you guys have enjoyed this PowerPoint exercise. I have enjoyed researching this subject. I've enjoyed working with the clinics and everything. I mean, it was just an eye opener, which also geared me to learn more about the opioid epidemic and other ways to help as well. So congratulations to all, and a good night.